Hi, and welcome back to Student Nurses Success. In this video, we are going to complete our review of the endocrine disorders by covering adrenocorticoid disorders and disorders related to ADH, antidiuretic hormone. Now, let's not waste any time because I know you are a busy nursing student. We're going to begin with our blank map. And let's first begin with the adrenocorticoid disorders. But as always, it's important to know what the hormones do, and then when we can talk about having too much or too little of the hormones. So remember, your adrenal glands produce cortisol, aldosterone, and the catecholamines. And the catecholamines are epinephrine and norepinephrine. Now, ACTH is the stimulating hormone that's released from the pituitary. And when that is released, it stimulates the production of cortisol and androgens from the adrenal glands. So when your cortisol levels go down, your pituitary gland senses that and releases ACTH to stimulate those adrenal glands to make more. Now, remember what cortisol does for you. Cortisol is important in increasing blood sugar and glucose release from the liver for energy in fight or flight. It's also anti-inflammatory. However, when cortisol is produced or long-term you're putting out high amounts of cortisol, it can result in decreased immune response. Aldosterone is important as well. Aldosterone causes the retention of sodium, and whenever you retain sodium, water follows through, and that will lead to an increased fluid volume. So we see increased sodium and decreased potassium when aldosterone is increased. Now let's start with our adrenocortical disorders. And the first one I want to talk about is Addison's disease. Now, there's a picture of John F. Kennedy right here, and that's to help you remember Addison's disease. He actually had it. With Addison's disease, the adrenal glands are not making enough cortisol and they're not making enough aldosterone. As far as the cause of Addison's disease, it can be autoimmune, where you attack your own adrenal glands and then they will stop producing these. It can be idiopathic. We don't know why it occurs, but maybe your adrenal glands just quit making enough of these mediators. Or it could be from the abrupt withdrawal of prednisone. And let me explain that because that's kind of an interesting piece here. When individuals take prednisone for whatever reason, maybe they're taking it for a asthma, or maybe they're taking it for some type of autoinflammatory or autoimmune disorder. When they take high doses of prednisone, prednisone is a glucocorticoid. And when they take high amounts of it, the pituitary gland senses these high amounts of cortisol and backs off on the production of ACTH. And so it decides that it doesn't need to make ACTH because there's enough cortisol present. However, if you abruptly withdraw or stop the prednisone, then the body is left without enough cortisol and ACTH is not being produced in order to stimulate the production of cortisol. So that's why whenever patients are on long-term prednisone, you taper the dose down. When you taper the dose down, it gives your body time to start producing ACTH. Now, in Addison's disease, this decreased amounts of cortisol and decreased aldosterone results in anorexia, hypotension or low blood pressure, nausea, vomiting, increased potassium, and decreased sodium levels. Now, let's talk about our primary or secondary causes of adrenocortical insufficiency. So, if we're talking about primary, we have decreased cortisol because Addison's is not enough cortisol. And the problem in primary is at the gland. So the adrenal glands are not producing enough cortisol. However, there is no problem with the pituitary gland. And so the pituitary gland senses a decrease in cortisol. When it senses a decrease in cortisol, it increases production of ACTH and CRH to try to force the adrenal gland to make more cortisol. However, if the adrenal gland is not functioning properly, it just can't do it. So in primary Addison's disease, we see a decrease in cortisol and an increase in ACTH. Again, you see that opposite direction. In secondary, that means the problem is at the releasing site. So the problem is at the pituitary gland. The pituitary gland is not making enough ACTH, and therefore the adrenal glands never know to make cortisol, and they have decreased amounts of cortisol. So we see those moving in the same direction. Let's talk about Cushing's syndrome. Cushing's syndrome is the opposite. In Cushing's, we have too much cortisol. It can be from excessive ACTH production. Maybe the pituitary is making too much ACTH, which is making the adrenal glands continue to produce cortisol. But often it is due to the overuse of prednisone. Now, up above, we talked about Addison's being the abrupt withdrawal of prednisone. In Cushing's, we often see that caused by the overuse of prednisone or taking too much prednisone. Now, sometimes we need to take a lot of prednisone for the disorder. We need that large amount of anti-inflammatory effects that it makes. However, when we take a large amounts of prednisone, we do see some side effects in the body. We see increase in weight or weight gain, a classic moon face, thinning of the skin, bruising, poor wound healing, overall increase of blood sugar, and increase of body fat. So this picture over here is supposed to kind of help demonstrate that. So Cushing's can be from overactive adrenal glands, but more commonly we see it in patients who just have to take high doses of prednisone for long periods of time. Let's move over and talk about hyperaldosteronism or Conn syndrome. Hyperaldosteronism or Conn syndrome is, as you guessed, too much aldosterone production. When we make too much aldosterone, we see an increase in our sodium levels and a decrease in our potassium levels. Most commonly, the cause of Conn syndrome is from overaction of the RAS system or the renin angiotensin aldosterone system or the RAS. What happens when the RAS system overacts? It's usually related to decreased cardiac output and decreased renal blood flow. When you have decreased flow to the kidneys, what happens is the kidneys overreact and institute the RAS system. They do that because they assume the reason they're not getting enough blood flow to the kidney is because there's not enough blood volume, which may or may not be the case. And so when they start the RAS system, what this does is cause sodium increase in sodium reabsorption, which leads to an increase in water and an increase in aldosterone and fluid volume. Now we see this a lot of times happen in either renal failure or heart disease when patients are in heart failure. Because in heart failure, you have decreased cardiac output, and this decreased cardiac output leads to decreased renal blood flow, and that leads to the RAS system. So again, the biggest cause of Conn syndrome is either heart failure, which this little guy over here, or renal failure. Those are the two most common causes. Now, when in hyperaldosteronism, you're going to see this drop in potassium levels. You're going to see this fluid and sodium retention. You may see the development of alkalosis, and you're going to see decreased urine output because the body's holding on to fluid. We're going to go over here and talk about congenital adrenal hyperplasia. It's not as common, but it is something that we do hear about occasionally. Congenital adrenal hyperplasia, or CAH, is actually in infants and newborns specifically. What CAH is it's genetic, and the baby is born not making enough cortisol. When they don't have enough cortisol levels, it makes the pituitary gland increase the development of ACTH because it's trying to stimulate the adrenal glands to make more cortisol. So it increases ACTH. The problem is when you start to increase ACTH, you also increase the production of androgens. So in this particular case, it may appear because of this increased androgens that females appear more masculinized. So their genitalia will look more masculine in nature. Now, the easiest thing to do is to treat it with cortisol. And that's what we do is replace cortisol for those infants. Now let's move down to our disorders of ADH. ADH is antidiuretic hormone. Remember, ADH means to hold fluid. So it's going to increase fluid volume. ADH is released when the body senses a decrease in volume and osmolality. And so what that does is it increases or decreases ADH production depending on what the body needs. If the body needs more volume, it's going to go ahead and increase ADH. If it needs less volume, it's going to decrease it. Now, we can have disorders related to ADH. The first one is going to be SIADH. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. What you see in SIADH is increased production of ADH. So you're making too much ADH. And as this picture shows, you're going to become fluid volume overloaded if you make too much ADH. When your fluid volume overloaded, you actually start to see a decrease in your sodium levels. This is a relative decrease. Think about it. If you're retaining more water, what sodium you have available becomes diluted. And that's why you start to see this drop in sodium levels because you have so much water and it's diluting out the amount of sodium that you have. With fluid volume overload, you also see an increase in blood pressure. Because you are increasing antidiuretic hormone, you do not have much urine output, so you have a decrease in your urine output, and that urine that you are putting out is very concentrated. So you see an increase in specific gravity, and it's usually very concentrated urine because you're not putting much out. Our other ADH disorder is diabetes insipidus. Now, diabetes insipidus, often referred to as DI, has absolutely nothing to do with blood sugar. Okay? What it has to do with is polyuria and polydipsia, which are two of the symptoms of diabetes. But we also, with DI, we just have the polyuria and the polydipsia. Remember, polyuria is increase in urine output, and polydipsia is thirst. And so this guy here is dehydrated and looks very thirsty. In DI, you have excessive fluid loss. You are just peeing out and peeing out and peeing out. You have so much urine output, you are actually dehydrating yourself. And so patients present fluid volume deficient or dehydrated. Because they're dehydrated and deficient on volume, their blood pressure is low. Now, what we see is an increase in sodium level. And again, this is a relative increase. Think about it. Just like we did with ADH, let's go ahead and apply this concept to DI. If you are decreased in your volume and you don't have enough fluid, what sodium you have is going to look very concentrated. And so patients actually appear hypernatremic or an increase in sodium. Other symptoms include this large amount of diuresis where they'll just keep urinating and urinating and urinating and urinating. It doesn't matter if you quit giving them fluid, they're going to just dehydrate and keep urinating all their fluid out. What's interesting is you would think they're dehydrated and so that their urine would be concentrated, but it is not. They're actually peeing out large amounts of dilute urine, so their specific gravity is very low. So it's large amounts of dilute urine. And there you have it, your completed map. And now you are done with your endocrine disorders. Again, remember the link to the maps is in the comments section.